Hello, everybody, and welcome to the virtual seminar series on Gaussian processes, spatial-temporal modeling, and decision-making systems. And I'm really excited to have everybody here. Thank you all for joining us. My name's Alex. I'm a postdoc at the University of Cambridge and one of the organizers who will be hosting today's event. And I'd like to thank my fellow organizers, Jeff Pleiss, Lisa Simonova, and Zi Wang, for helping to put this seminar series together. Before we begin today, I'd like to make a few organizational announcements. First off, we've got an amazing set of speakers that you can find on our website for upcoming talks. The website is gp-seminar-series.github.io, and I'll put a link into the chat. And so check it out. You can join seminars via Zoom, provided you register to receive emails, which can be done on the website, or you can join via the YouTube live stream, which does not require registrations. Seminars take place at 1600 UTC, which is Coordinated Universal Time. We've just had a time change in the UK, so be mindful of what that time is in your local time zone. And if you're joining via Zoom, you can use Zoom's raise your hand option to ask questions or type them into the chat. And the speaker can choose to pause and answer questions during the talk or hold questions to the end, depending on their preferences. And with all of this said, it's my great pleasure to introduce Marta Blangiardo, Chair in Biostatistics at Imperial College London, who will give today's seminar on spatial and spatiotemporal models in the time of COVID-19. Marta, the floor is yours.
Thank you very much, Alex, and thanks, Lisa, for the invite. I'm really excited to be here. And let me try and share the screen again. Hopefully it's fine. Yes. Can you see everything? Yeah, hopefully.
Yes.
Okay, great. So I'm gonna talk to you today about some recent work, sort of like which covers the last couple of years, because obviously it's related to COVID. And I realized I've been a bit general in the title, sort of like considering this is a seminar on, spatial and spatial-temporal models. Calling it spatial-temporal models in the time of COVID-19 was a little bit general, and I know lots of people, I'm sure, actually I know some people in the audience as well, have been working on COVID as 90% probably of statisticians during the past 2 years. So what I'm going to present today is a little bit, to go a bit more specific, is about modeling excess mortality. And so I'm going to start just saying with a little background about why excess mortality. And while measuring the impact of COVID pandemic on mortality should be really the least controversial outcome. We kind of like mortality is the easiest outcome to measure. We still have complications because there was a lack of real-time cause-specific data, particularly at the beginning. There was no ICD code, for instance, for COVID. There was a loss of misclassification, which was sort of like very much depending on the practitioner who was diagnosing, for instance, the person. And so it was kind of like really, let's say non-differential. And also the quality of coding of that on that certificate, which is very much related to that. Once we had that certificate, there was a lot of sort of like, confusion, particularly at the beginning, about what was sort of like this new disease. And excess mortality has been used before, is nothing really new. And during the COVID pandemic has been used quite a lot because it allowed actually to look at the total impact of the pandemic, not only the direct impact of the COVID disease, but also covering all the other aspects which were related to change in behavior, people who didn't want to go to hospital, people who could not be admitted to hospital during lockdown, people who were scared, they were changing the ways, they were behaving, also healthcare changes, social changes, and so on. So this has been used quite a lot. So if you just Google excess mortality COVID, you'll see sort of like lots of papers on it. And just to give you a very quick sort of like just a very quick overview. This paper was one of the biggest, which looked at particularly the first wave. There is also like a follow-up paper looking at the entire first year of COVID. But basically they sort of like develop the model for the model that they use for excess mortality in this paper. And basically it's a Bayesian model, not very dissimilar to the one I'm going to present later, and is looking at national level, weekly data of mortality. And the idea behind excess mortality, and we'll see it later, is really comparing, basically using years before the pandemic as a control and sort of like looking at the trend in mortality there, and then trying to predict what would have happened in the scenario of no pandemic. And then comparing the prediction with the observed data. So this was one of the main contribution. There were also other contributions more sort of like towards getting together data sets. So this is a very interesting one where basically the authors built a database from 103 countries. So it's really huge and it's freely available on GitHub and is, I think, still weekly updated. And then they sort of like had some very simple modeling at country level again with some sort of like very simple, you know, slope by for the different years, and then a weekly kind of like intercept. But the idea here is to kind of like pull together all this data, and you know, it's really a good resource for people who want to use it. And then there are kind of like more dashboards, which are sort of like mostly put together by, you know, for stakeholders. And this is one of this is my most famous one. It's in Europe, for instance. There is one in the UK specific for the UK. There is one from the US, from the CDC. This was kind of like covering most of Europe and providing nice plots for excess mortality by sex and age groups and so on for the different countries. So as this is just really a very quick overview, but there is plenty. As I said, if you Google it, you'll see it. What is kind of like in common among all these resources is that the focus is mostly on national data. Some of the papers, particularly the later ones, have looked maybe at regional level, but still quite coarse from a spatial sort of like, you know, perspective. There are some exceptions, but it's just a few. While I would argue that if we want to really understand the dynamic of the pandemic, we really need to move to a subnational level. And I'm not saying that the country level or regional level estimates are not useful, actually quite the contrary. I think particularly at the beginning, they were really, you know, useful. And particularly when you want to do a comparison maybe across, you know, 100 countries, it sort of like makes sense to do something at national level. What I'm saying is that if we want to really try and understand, one, are there geographical differences within the countries? And two, you know, can we explain why there are some differences? We really need to go at the subnational level. So what I'm presenting today is sort of hopefully to sort of split in two. The first one is based on a paper which we published recently in Nature Communications. It's a massive effort, lots of people involved, all here from 5 countries, and is estimating regional excess mortality for over 1 year of the pandemic in 5 European countries. The second one is more looking into try to explain, as I said, sort of like, again, going subnational and trying to explain if there are community level characteristics which somehow are related to the differences in excess mortality that we see at geographical level. And in this case, we are talking about 3 countries, England, Italy, and Sweden. Again, quite a lot of people involved in this, and this is under review on the European Journal of Epidemiology. So I'm going to go straight into the first piece, and I'm just going to say that is an analysis of the spatial-temporal differences in excess mortality in the 5 countries. So the 5 countries are England, Greece, Italy, Spain, and Switzerland. And How we chose the countries, sort of like part of it was we had a good network across the 5 countries, so it was easy to work with this, with the collaborators. Also, actually, this country represents quite a good selection of European countries where we get some which were very affected at the beginning, some which were kind of like affected overall, some which were not really affected very much, but maybe because we had different also non-pharmaceutical interventions. So it's kind of like a combination. Obviously, the population is different as well. The social demographic are kind of like different across. So the healthcare system as well. So really, it's sort of like a good representation. And we used a population-based design. We consider weekly all-cause mortality, and as I said, we're covering 1 year, so from the 1st of January 2020 to the 3rd of January 2021. And this is going at subnational level, as I said, so we're considering NUTS3 regions. And if you're not familiar with NUTS3 regions, which sort of like stands for Nomenclature of Territorial Units for Statistics, is kind of like a type of splitting of the space, so that you can kind of like find it consistent somehow across the world, basically. So obviously here we really needed to find some geographical representation which was consistent across the 5 countries, so we used that. But then obviously we kind of like have always the opportunity to sort of like aggregate up. So that's the other thing, right? When we go at subnational level, it's easy then to aggregate up. Obviously, you cannot do that as easy if you sort of like start with the national level and then you want to sort of like split. So some results we aggregated at NUTS2 level, which is sort of like the regional level, or at national level. We stratified by age classes and sex, and the comparison period, as I said, for excess mortality, you need a comparison period. Typically, it's the 5 years before the period you want to consider as your study period. So we had 2015 to 2019. And we used a spatial-temporal Bayesian modeling framework, which, as we all know, I don't have to justify this here, but we can model dependency and propagate uncertainties very easily. Right, so obviously we need a denominator because we have the number of deaths and we sort of like want to have some sort of estimates of risk. So we need a denominator, as I said. And what is typically used is the population. So we have yearly estimates of the population for 2015-2020 across the 5 countries, which basically were done 1st of Jan 2015, 16, 17, up to 2020. So we used that, and then sort of like with a very simple linear prediction, we predicted 1st of January 2021. And then this was done split by age, sex, and at the NUTS3 regional small area level. And then we also, because our model is at weekly level, we wanted to have a weekly population ideally. So what we did was for each year, from the beginning to the end, we sort of like used again some linear interpolation to assign the population to each week. And I know this is sort of like quite simplistic. I mean, don't get me wrong, it's kind of like better than what was done in previous paper where they just use the same population across. But obviously, we know it's not perfect. And the other thing is, obviously, we know we're not really accounting for uncertainty. And this is opening another kind of worm, which, we can discuss later if you want, which is sort of like what is generally done. The denominator, you tend not to consider uncertainty on it, which is, I know is wrong, but it is what it is. Now, we sort of like wanted to account for the factors which can affect mortality. And temperature and holidays are 2 of these factors. The temperature, we know there is usually this U shape. So cold temperature are pretty bad for health, and hot temperature as well, high temperatures. So this is sort of like just to give you an idea of the typical shape. And I think this is for 80 years old and older, males and females. So we used information from the Copernicus climate data, which is reanalyzed in the ERA 5 data set. And it's quite a very, it's a very big, very nice data set, which gives hourly estimates. We at a specific grid, which is 0.25 degrees, which is basically, I think, something like 25-30 kilometers at this latitude, more or less. So we sort of like just use the centroid and assign it to the NUTS 3 regions. We calculate the daily mean and then the weekly mean. So basically we had it aligned with the mortality data. And then also we accounted for holidays, just because it's sort of like, it's quite well known that on Saturday and Sundays, the sort of like mortality, the deaths are not registered basically. So we just included a binary variable, nothing really complicated. So let me go into the notation. So for each country, it's obviously, it's important to say, we have done the analysis separate for each country. So we had this Y, which is the number of all-cause deaths in a specific week J, year T for the NUT3 area S, and age sex group K. So age sex groups, we have obviously males, females, and then we had this 5 groups, so below 40, 40, 51, 40, 59, and so on, that you can see here, up to 80 plus. The population P, same resolution, same sort of like index, J, T, S, and K, which we got as I explained before. Then the rho is the risk of death, or sort of approximates the mortality rates in the specific week J, year T for the region S, and age sex group K. Then we had the dummy for the holiday, and X, which is the temperature. And obviously X and Z, they don't change by strata, let me say. Now then, in the main analysis, we excluded the younger group, so we excluded the one below 40 based on cross-validation. I'm going to say something about it in a bit. They were kind of like less affected by the early, at least the early waves of the pandemic, I would say in general. Obviously, they were the least affected. But so we kind of like just removed them from the analysis. So the aim of this model is to predict the number of deaths in 2020 under the hypothesis of no pandemic. So we have the number of deaths Poisson distributed with the offset P, the population, and rho, which is the risk. And then with the log linear model, very simple, where we include a bunch of effects. So we have an intercept, which is depending on the year. And obviously, this is done for 2015, 2019. Okay, so the 2020 is out of the picture at the moment. So kind of like there is a near specific intercept with an unstructured random effect. There is the effect of holiday. There is the effect of temperature, on which we want to sort of like, as I showed you before, is sort of like a nonlinear effect. So we approximated it using a random walk of order 2. And then there is the spatial effect and sort of like overall temporal effect. Now, the spatial effect, we used the typical BYM model. So if you're not familiar with it, it's basically a combination of 2 random effects, one which is unstructured, so sort of like an heterogeneity effect, and one which is spatially structured. So basically it depends on neighborhood. So for a specific area, the value, the estimate of the random effect would depend on the ones around. And there are 2 hyperparameters on this, one which is the phi, and is the weight of the spatially structured versus non-structured random effect, and the tau, which is the precision. And then finally, the global temporal trend, we used a random walk of order 1, which we also tried with random walk of order 2, but it was not needed. I mean, random walk of order 1 was more than enough. So it was counting for seasonal variation. Right, so as I said, the model is built for 2015-2019. Then what we do is use posterior predictive distribution to estimate the number of deaths in 2020 under the scenario where basically the pandemic didn't happen. the happy scenario in which the pandemic didn't happen. So, you know, we have the posterior for the parameters, and we predict from the same Poisson distribution using the posterior theta rather than the prior, and we average out all the uncertainty on the parameters. So the classic predictive distribution. And then the excess mortality distribution, we estimated as the difference, the relative difference between what we observe in 2020 and what we predict compared to what would be relative to what would be the predicted, basically. So this would give us, and then we, you know, we kind of like, you get it percent, and then we get percentage of excess mortality. Excuse me. Right, the implementation is done in INLA. And simply for sort of like, it was very fast to run, and it's, you know, it's kind of like INLA has been now used for many years. It provides a very nice approximation. It's sort of like, it's faster than general and CMC, so we use that. If you are not super familiar with INLA, I'm going to spend the next 5 minutes just giving a very brief overview. If you are super familiar with it, you can just switch off and think about something else. So there are 3 main ingredients. It works on latent Gaussian models. The assumption is the Gaussian Markov random fields, and it uses, as I said, the Laplace approximation, as the name says. So in general, a latent Gaussian model, we can see it as the sort of like combination of these 3 elements. We have the data model, so basically the distribution of the data y given parameters and hyperparameters. The parameters, which is sort of like the process we want to estimate, given the hyperparameters, and this needs to sort of like be, this needs to be normal with a precision matrix. And the precision matrix depends on the psi, which sort of like, which is our hyperparameter. Now, what usually happens, to be honest, this is an assumption, but it works very well most of the time, is that in the latent field there is conditional independence property. So if we have 2 theta, theta L and theta M, if they're independent given all the rest of theta, then the corresponding Q element is going to be 0. So this means the Q matrix is sparse, and so theta is a Gaussian Markov random field. So what we want to estimate in a Bayesian latent Gaussian model are this posterior distribution, the distribution, margin of posterior distribution for theta, and so for the process parameters and for the hyperparameters. And it's sort of like just rewritten here. And we kind of like use the Laplace approximation for getting this. And while the dimension of theta can be very large, it doesn't really matter how large, you know, to some extent, which is great because actually the theta are going to be our, you know, sort of like linear predictor, the combination of our linear predictor at the area level, at the weekly level. The dimension of psi, on the other hand, should be relatively small. Those are the hyperparameters. Typically less than 20 is recommended, and usually that's okay. You know, it's kind of like just the hyperparameters involved in the random walk, for instance, the different precisions for the random effect, for instance, and maybe the hyperparameters for the phi, for instance, the phi for the spatial BYM. Now, obviously, INLA is very fast because it is a deterministic approximation rather than sort of like doing a random simulation. The correlation are modeled with a Markov property, so the dependence is only on neighbors. So we have basically a sparse precision matrix, and so this is computationally advantageous. So really, in a nutshell, how INLA works is first you sort of like start with the hyperparameters, you get a grid of points. Using the Laplace approximation, you get the posterior, you kind of like get the mode, and then you get this grid of points to sort of like go over all the space of the posterior, and then also associated area weights. And so kind of like this is used to approximate the posterior. And then conditional on each of these points in the grid, using again the Laplace approximation, you get posterior for each of your parameters theta. And basically this is what we would get. You know, this is using, this is would be a posterior of theta given a specific point in the grid for psi. And then basically weighting by the delta, which were the weights for each of the grid points of psi. This is what we would get, and then you kind of like just sum over and you get the posterior that you are interested in for each of the theta. And I'm not going to go into any technical detail. If you're interested in it, obviously there are plenty of papers, books, and everything else to look at. But it's just works very well with this for these types of application. So going back to the model, we performed cross-validation, and basically we did this in this way. We just forgot, we just completely ignored the 2020. We used 2015, 2019, leaving one out every time and trying to predict what the mortality would be in that left out year. This is done for the different age, sex groups, and countries. And then we use the correlation between predicted and observed deaths, and then 90% coverage for, just as a way to sort of like see how the model was doing. And actually the model were doing pretty well. We had correlation going from 83 to 97%. And then the range was from 90% to 95%. So that was really good. The only group in which we didn't really do very well was the younger group. So for the 40, for the one below 40, while the coverage was good, was still 95%, around 95%, the correlation was much lower. And I think it's because actually we had quite small numbers. So while the coverage was able to pick it, so the uncertainty was sort of like good, but then the correlation was not picking it up very well. So we decided to just remove it from the analysis. Yes, I'm just going to show you some results in terms of national trends and some maps. So this is what we got. And as I said, we started at the NAS3 region, and then we aggregated up nationally, for instance, here. And this was quite nice because then we could compare with all the other resources which provided national estimates. So in England, for instance, you can kind of like see this is the observed, and this sort of like with the shades is the basically the posterior distribution of the predicted. And you can see that actually there is a massive first wave for males and females across. Italy is another one which had like a first, but also a second wave, and that was quite sort of like striking for across for males. For females, sort of like it started to get, visible for sort of like older ages. Spain was another one with just a first, sort of like a first wave mostly. And then you get Switzerland, where basically there was nothing except towards the very end, where for the older age groups, you could start seeing something. And Greece was quite similar. So it's interesting that two countries sort of like quite far away and quite different, they had sort of like similar sort of like behavior nationally. Now looking at excess mortality in space, this is the point estimate, so it's the posterior mean, and you could see, urban sort of like London, Midlands, Birmingham, Manchester, Liverpool in England, Greece with this north versus south, Italy, really the north. Spain was kind of like across, everything was a little bit red, and in Switzerland there wasn't a lot going on. The good thing about this type of models, obviously, the Bayesian approach, is that you get also the posterior probability, and the posterior probability, you decide which kind of threshold you want. Just really looking at the posterior probability, exceedance probability of, an excess, so really getting, any excess deaths, actually, you see that even in Switzerland, there is sort of like, there is excess, it might be not so high, but it is there. It's sort of like, almost everywhere. So what we learned so far was that there was a wide variation in 2020 excess mortality within and across countries. Spain had the largest excess mortality. With Greece and Italy, there was a very strong spatial gradient, probably for different reasons. There was a temporal pattern in all countries, maybe a bit less for Greece, and I would say possibly a bit less for Greece and Switzerland. I think in terms of temporal pattern, they were sort of like quite similar. We compared our results with what was found in the literature, particularly from the different statistics institute in the different countries, and the estimates we got, they were quite in agreement. For England, we had something a little bit lower, but if you looked at the intervals, accounting for the uncertainty, it was fine. There's a lot of discussion to around this, and one thing would be to kind of like suggest that if you had a timely lockdown, as for instance in Greece, and to some extent also in Italy, that reduced obviously community transmission, so that's lowered excess mortality, which in Greece was kind of like everywhere, it's pretty low. In Italy, by when the lockdown went in place, actually it was already spread everywhere in the north, but actually didn't really go too much into the south, while in the absence of a lockdown, probably things might have gone much worse. Now, what we cannot answer so far is, are there variables that can explain the differences? So we obviously see differences in space. Is there something which is associated with that? And so we did that using, again, a similar framework. And so the aim here was really to evaluate the role of area level covariates on explaining the spatial pattern of excess mortality. So it's a similar framework, but it's a slightly different model. So here we use the two-stage spatial model. And we obviously, the idea was to really try and quantify inequalities. And during the first year of the pandemic, the first year in this analysis actually starts from March 2020 to February 2021, rather than beginning of January to end of the year. But the comparison period is the same, 2015, 2019. I didn't say, but actually, so it's across 3 countries here rather than 5. 2 of them overlap, 1 doesn't. So we again needed some consistent geography across the countries, and I mean, we could have used the NAS3 regions, except that we had problems for Italy, and not because of the mortality, but actually because of the mortality. So we didn't have mortality at a higher spatial resolution than municipality, and municipality is a weird geography because you get very small municipalities in the mountains, where sort of like the smallest is 30 people, and very massive ones, like Rome or Milan, Naples. So, and you will see this kind of like has an impact on the results. For England and Sweden, they were a little bit more comparable, even though obviously Sweden is a smaller country. So the population, it's smaller at the level of spatial level we consider, which is this DESO. But in a way, it was the most comparable we could find with England. While England, we used exactly the same that we used in the previous analysis, which is middle super output area. And you can see the population goes from 2000 to 26. Now, the other challenge here was trying to find consistent covariates. And that wasn't very easy. So obviously we wanted to cover things like deprivation, and deprivation was not that bad because there is an index for multiple deprivation in England. There is an index for multiple deprivation in Italy. In Sweden, there isn't. We used income deprivation. Air pollution was fine because we were using something at the European level. So it was easy to sort of like find exactly the same source across. Living condition was also a little bit tricky because in England, usually we use overcrowding, while in Italy, they didn't have anything like that. And in Sweden also, so they had the sort of like density, how many people for how many, for a specific area of the living space. And then population density obviously was the same. And then we used movement of people, the sort of like Google mobility data. Okay, so the notation is very similar to the previous one. Y is TSK, where now T is the year. We don't really have the week here, so we're kind of like covering the entire the entire year. T is the year, S is the small area, and the age sex group is the K. And then we use exactly the same age groups as before, and we drop again the one below 40. P is still the population at risk. Now we have this row, which in this analysis we have two basically, because it's a two-stage analysis. Basically, we have this row 0, which covers the control period, and I'm telling you in a minute, I'm going to show you the model. And then the second one, the row 1, is for 2020. And then the X in this case is community level characteristics for the specific small area. Now, the analysis is stratified by sex and country, while the all ages were included in the same model in this analysis. So the aim of the first stage of the model is to estimate mortality rates at area level for the comparison period. So again, Poisson distribution on the number of deaths for a specific year, area, and strata. And here we have the usual that we had before, year-specific intercept. And then we had an age-specific random effect. And then we had, not even a random effect, is like independent, effect, so a fixed effect for age. And then we had the spatial random effect. And the spatial random effect, we used a similar BYM prior as I explained before. Now, the second stage is the aim is to estimate the ratio between the death rates. So it's sort of like a risk ratio in 2020 and in the comparison period. So basically this means for the Poisson distribution of the deaths of 2020, we split the row into row 0 times row 1, where row 1 is actually the ratio between the 2020 and the one before, the one in the control period. And then this is actually, sort of like estimating the excess. And we are then including our covariates in this log linear model. We have again a spatial effect, we have again an effect of age, and we have again a global intercept. The covariates are included in quintiles. And then we also propagate, which is important, we propagate uncertainty from the stage 1 to stage 2, sort of like doing kind of rerunning using a sample of the posterior, using a sample from the posterior of row 0. We included it in here, sort of like resampling and rerunning the model. The posterior distribution of the estimated number of deaths is this, which is sort of like nothing complicated. We're just multiplying the rates by the population, and then we just do the difference or the sort of like the ratio, depending if we want something absolute or relative, between what is observed, estimated in this case, but estimated based on the rates of 2020, and what is estimated based on the control period. Again, the model is implemented in INLA. And what we found is that more than 90% of the areas in England and Italy have excess deaths, while in Sweden the situation was much better. We only had 70% for males and 55% for females. About 60% of areas in England and Italy have basically a posterior probability higher than 90% of excess deaths, while in Sweden this is really small. And we see that excess deaths is always larger for males than females. And this is, this is similar to what we saw before in the previous analysis. Now, this one is just kind of like, and I apologize because you can't really see the labels and all the labels here with the variables, but I'm gonna go through it. It's just to give you a very descriptive picture of the variables and excess mortality at the area level across the different countries. So we were trying to see if actually you could see an effect of the variables on excess mortality. And again, this is not from a model. I mean, this comes from a the excess mortality comes from the model, but this is just taking the quintiles of the different variables. The first two are air pollution, PM and NO2, then is population density, overcrowding, deprivation, and the Google mobility data. And then what we can see is that actually, for if you look at it from afar, for England, you see sort of like this block here. Oh, I didn't say the dark is the first quintile, the lighter is the highest quintile. So you can kind of see that where there is higher excess mortality, some of the variables seem to be quite related to that. It is similar to some extent for Sweden. For males in particular, females is a bit of a blur. For Italy, I would say it's kind of like quite different. On the other hand, what is interesting to see also from this picture is that the level of uncertainty on excess mortality that we get for Italy and England is quite similar. For Sweden, it's really much large. Looking at excess mortality maps, we can see that in England, there is, again, similar to before, sort of like a lot of red, which is higher excess mortality in urban areas across the main, around the main cities, particularly for men. And it is interesting to see that the local clustering explains 30% of excess mortality for males and 15% for females, which is not a lot. I mean, it is a bit, it's not massive. And obviously this is the posterior probability, so you can actually see better that kind of like all this dark bluish have a posterior probability of an excess higher than 90. For Italy, you can appreciate, I'm sure, there is a lot of spatial clustering, particularly if you look sort of like, it's quite clear if you look here, but also from the actual point estimate. And in fact, the local clustering explains something like 80% for males and 65% for females. Sweden it's interesting in the sense that there isn't a lot of spatial clustering, something like 3% for females, and something like, sorry, I have the things called 5% for males. It's quite strange because of the way these DESO are created. Actually, I'm sure you cannot really see it, but for each one of these big areas, there is a dot inside, which is the main town in the area, and then the rest is the remaining of the sort of like the county, the province. So that's kind of like why there isn't really a lot of local clustering, which makes us questioning if this was the right sort of like level of geography, and we're thinking about that potentially for the future. So, and this was sort of like what we got in terms of relationship with the covariates. And what you can see, I'm just going to go, so this is England. So air pollution, the first two, population density, overcrowding, deprivation, and the workplace visits, which is this Google mobility data. So basically here is England, this is Italy, and this is Sweden. So again, Sweden and England are kind of aligned. Obviously, there's much more uncertainty on Sweden, but basically there is population density, which stands up, over deprivation, a little bit of air pollution, while Italy is kind of a bit different in the sense that there is a lot of air pollution, nothing on overcrowding. Deprivation is the one. And then there is this strange relationship with population density. Yeah. So just to conclude, we have run quite a few subnational analyses, and I think they're quite important to highlight differences in excess mortality, to see actually if there are differences, and then to try and understand if there are local characteristics which can explain these differences. This is particularly useful if then you want to sort of like try to get policies which are targeted. And it may be that in some countries that doesn't really make sense. In some other countries, this may actually be very helpful. Now, so uses spatial-temporal Bayesian models. It's flexible framework. We get, principles estimates based on probability. We have stable estimates for sparse data. We can account for correlation on linearities. We can report and model uncertainty very easily. And the future steps is to combine the excess mortality with COVID-specific mortality, because there's a lot of talk about dying with COVID and because of COVID, and it's sort of like something which I've heard here in England. In Italy, it's quite a big thing, has been quite a big thing in the past few months. So it's something that, we should be able to explore, having also COVID-specific mortality. And also seeing if the effect of community level characteristics changes in time, particularly between first and second wave, but even more generally, if it changes in time with some sort of, fluid kind of flexible way of accounting for time. Now, the last thing I just wanted to tell you is that obviously we have seen in this age of the pandemic also a lot of dashboards, lots of apps, lots of sort of like ways of visualizing results like this, and which is great. From complex models to audience that may not be super technical. So what we did was also sort of like put together a tutorial for using R to estimate and visualize excess mortality. And this was this flow chart showing, all the different packages for data wrangling, then for the modeling, for the sort of like getting the results out, and then for visualizing the results. And then we also have a Shiny app, and which, it's here, and you basically can go on it. It covers the 5 countries, and you can have a sort of like a purely spatial, or see the results purely spatial, purely temporal, or the spatial-temporal. And you could get for the different countries relative excess mortality and posterior probability estimate. And yes, so, and for the different ages and for the males and females. So we kind of like, we thought that this was a nice way of sort of like pulling together all the results and showing it to, for the general audience. And we're planning to do something similar for the for sort of like the second part of this talk, which is about the community level characteristics. I think I am finished. Thank you very much. If you want to reach me, there's Twitter, this is my website, and this is my email. That's it.
All right. I want to go ahead and thank Marta for the lovely talk today. And so we will now move to the question, answer, and discussion period, and we will have a period of questions that will be live streamed, following which we will conclude the live stream for those that prefer not to be recorded and continue discussion on Zoom. So for anybody that has any questions, you can please use the raise your hand button or just write in the chat, and the speaker can unmute you to ask your question.
Alex, sorry, can I ask, do you want me to stop sharing?
That's up to you, but feel free to if you prefer to sort of more interactive.
I'll do that.
I guess the only thing that it has is a thank you, so.
Yeah, okay, fantastic. Wait a minute, how do I do it? Yes, do it. Okay, right. Did I stop sharing? Yes.
And we have one question in the chat. Hopefully, if you can't see that, let me know.
Yes, I can see that. Okay, the question, should I read the question? Is thanks for the interesting talk. Just a suggestion, it would be interesting to include the effects of lockdown as well. From Amin. Yes, can I ask, I mean, and I don't know how to unmute you. Are you talking about the first part of the talk or the second part of the talk?
I've pressed the unmute button for Amin.
If I find Amin.
Hello, thank you. Yeah, I was talking about the first part.
Yes, well, in a way, it was already accounted for through this, you know, through the temporal pattern. I'm thinking if you include something, I mean, I'm not sure if we actually, if you actually need that because of this, you know, because we actually had, you know, temporal pattern in it, which was pretty flexible. So you should be able to pick when things changed. I think maybe it's more sort of like, I'm thinking more is the second part of the talk, which we may sort of like see a difference in the effect of some of the covariates, for instance, if you are in a period of lockdown, for instance, particularly in terms of behavior, which was something the Google, you know, the mobility data tried to do, but obviously they were not sort of like changing with time. We didn't really have anything changing with time. So I think that would be quite nice. And that was almost sort of like one of the things we would like to do in the future, which was sort of like looking at different waves. It could also be including something where I'm thinking more sort of like, as I said, a little bit more sort of time dependent, you know, in the effect of the covariates, and you could actually account for that more there, if that makes sense. Okay. Lisa, do you have a question?
Yes, I have a series of questions. As I think I'll start shooting them one by one, and then let other people ask theirs in between. So the first one is, so first of all, yeah, thank you very much for the talk on a very timely subject. And in case some of our listeners don't know, Marta has mentioned INLA, and she described some of the details. She actually is one of the two authors of a book called Spatial and Spatial-temporal Bayesian Models with R INLA. So in case someone here would like to pick up the tool, that's an excellent resource. So the first question is about the spatial models. Could you please comment on the choice of the model? So why BYM? So Bezier Mulder, right? Why not car or e-car or anything else?
Okay. So the BYM has the advantage of being a combination of the intrinsic conditional autoregressive, and then it has an heterogeneity component. So it is a little bit more flexible than just using the car. Obviously, you know, the car itself assumes that there is a structure. If there is no structure, it's kind of like, you know, you're imposing something which is not there. This is more flexible because with this phi hyperparameter, in case there is no structure at all, as we actually saw in the Sweden example, or maybe in the Sweden, in the second part of the talk on Sweden, actually there was basically no spatial clustering at all. The model is still doing okay because actually we get a phi which is really, really small, which means there is, you know, a lot of heterogeneity. It's sort of like just, you know, some shrinkage global, but you don't have the local structure. On the other hand, in a case like Italy, where we saw 80% of the local clustering, 80% of the variability explained by the local clustering is really, you know, the model is still able to pick it up. It's exactly the same model, but the phi in that case is much higher. And in terms of using that rather than using, for instance, something which is kind of like assuming continuous, a continuous field, is just that it is quite common with this aggregated data at area level, using this idea of neighborhood, because you kind of like, if you assume that you have quite small areas, it may make sense to actually, you know, think that there is some correlation across areas which are very close to each other, rather than, you know, very far apart. So that's how the structure is, that's why the structure is typically used.
Great, we have more questions in the chat.
So who is here? First there was, oh wait, okay, Roman says, I'm really not very good at unmuting people. I don't know.
I will press the unmute button for Roman if I can find.
Roman, yes. What is your question?
Hi there. Thanks for sharing your work, Marta.
Sure.
Yeah, just first a question and then a comment over that question. At which spatial support your observations are available?
Is for the first of the two parts, it was available at the NUTS3 regions, which, for instance, in England, that is MSOA level, it's middle super output area. But for instance, in Italy, it was province level.
Okay.
And Switzerland was canton level, I think, for instance.
Okay, great. And over that question, because you are kind of, well, you're using estimates for population. Does it make sense to provide estimates at a finer spatial support, and of course use your observations at these nutri levels, but using like a high resolution population estimates?
You mean higher than the resolution that we used for the health data?
Yeah, exactly.
Mm.
I mean, after all, there is some aggregation bias on using these aerial data, right? So that will be a way to address that at least some aggregation bias.
I don't know, because the population has the same problem. I mean, the population is an estimate as well. And the highest the resolution for the population, the more unstable it becomes. So I think, I'm not sure that using population at a higher resolution than the one we have the health data available would actually help. What I think we should be doing in general, and it's not really done, but you know, it's something we're working on, is trying to include uncertainty on the estimates of the population, because as you're saying, they are estimates. So, you know, it's like all based on the census. And then there are, like, for instance, the ONS in England, they give this yearly estimates, but it comes out of a model. So we use them as sort of like face value, but actually there is an error, and that would affect, you know, the sort of like the model. So we should really account for that, and we are not doing it, but you know, in the future, we're going towards that direction.
Okay. And last question about that, related to that. It will be useful to maybe change the spatial support to a grid, for instance, to better capture the spatial structure instead of using these administrative units?
The problem is data availability. So we were kind of like bound to the availability of the health data.
Okay.
So I think, you know, it is interesting. It would be interesting to try something where we have the data. Presumably it's more for when, I mean, I think for the prediction of the excess mortality per se, administrative units work very well. For the linking with covariates, I agree that with some covariates like air pollution, they're not like, they don't change, it's like we had to aggregate sort of like at the administrative level, while that is a continuous surface. So it may make sense to try some alternative way of just, sort of like selecting the space. To be honest, the biggest problem we had was for Italy, where we had this massive change in population for the different municipalities. So in that case, obviously it would have been much better to try and change the spatial aggregation. The problem was the data that we only had at that resolution. So, the health data, so we couldn't really do much else, unfortunately.
Okay. Well, thanks a lot for your thoughts.
Should I go through the chat? Because I see also, Alex, you have a question. Do you want me to?
Yeah, I'm behind the people in the chat, so the people in the chat should go first.
Right. So there is Sam who is saying, well, maybe I'll ask Sam to summarize the questions. Seems quite a long one.
Great, thanks. Well, first of all, thank you. That was a really nice talk. So I had a couple of questions. They're sort of discrete. But the first one was, you mentioned you use cross-validation, and I think it was correlation and coverage to validate your model.
Yeah.
And I was just wondering if you considered time-aware cross-validation and proper scoring rules, and if you did, why you didn't go with that approach?
We didn't.
Right. Okay. Fair enough.
Which is, a nice suggestion. I think, we sort of like went for something quite simple. But yeah, I mean, sure. I think it's a good suggestion. We could have done that.
Yeah, fair enough. And sort of related to that, did you explore other model variants? Like how, really what I'm getting at is you already sort of talked through that. How did you establish that the model was performing like well enough? Because all of these validation things, they tell you in comparison to other models how you're doing. How did you decide, oh yeah, this model is good enough, we can stop now?
Well, we haven't really done sort of like, a proper model selection, I would say. We haven't done at all model selection. Yeah, no, we haven't done it. So I think, we were happy with the fact that at least in terms of cross-validation, it seemed to be not going, sort of doing weird things on the control periods. So basically we didn't really get any excess mortality for that period. Obviously, I mean, maybe the temperature could have been better linear, or obviously you could, in a way, this is what the other paper I sort of like mentioned at the beginning did. They had this ensemble of 16, I think, models, and they kind of like then did some Bayesian model averaging. We kind of like haven't done that. We ended up with very similar estimates to them. Yeah. So yes.
Fair enough. Thank you. That's really useful. And just finally, I was looking at the last paper you were discussing, and I was just wondering if the code's available, because I saw that there's code snippets, but not the full code. I was just wondering if that was public somewhere.
For the second paper, you mean the one with the covariate?
Yeah, the two-stage model and the covariates. Yeah.
Well, I wanted to put it on GitHub. It's not. I don't think we have, but we can definitely share it. I think it's yeah. We can definitely share it if you want. Just drop him an email. I will. I think at some point we're going to put it on GitHub. We are sort of. The paper is under review at the moment, and we sort of like tried to be quite, we put all the effort in sending the paper as soon as possible, but now there are a few things that we want to sort of like do, and in terms of dissemination. So definitely one thing is to put the codes available on GitHub. But if you need it, if you want to use it sort of like in the next few days or something, just drop me an email and I can direct you to the person who can send it to you. No problem.
Okay, awesome. I will. I'm more just interested, but it's good to get these things done fast. So thanks. Thanks very much.
The tutorial is on The tutorial is under review as well on the art journal. So I think there is a preprint, but let me check that. And obviously that is on GitHub. I can send you the link. Yeah.
Okay, excellent. Thanks very much.
Right, next one is Adam.
Hey, thanks for the talk. So the question was just about, so you decided to drop the data for the under 40s, and I guess that data was the sparsest since they were dying at lower rates, and that would have been where the model would have been doing the most work. Whereas for the other data, perhaps, you know, with smoothing models, it's mostly interpolation. So I was wondering why you decided to make that decision, given that potentially, you know, the uncertainty for the under 40s would have been reflected by the Bayesian model anyway. Thanks.
Well, there was a big discussion, to be honest, about this below 40, because in fact, in terms of prediction, we were not doing bad. It was just a correlation which was a little bit all over the place. And also the fact that, I mean, maybe if we had, I don't know, it's sort of like a model with everything in it, you know, all the ages as well, it would have sort of like make more sense. I mean, looking at the estimates that we had, you know, we actually ran it on the below 40. It's not that we didn't include it in the final paper because we weren't completely happy with the results. So in a way, I'm thinking the model is not doing great in terms of, you know, getting to your point. It was kind of like probably not doing, you know, as much sort of like borrowing of strength as we would have expected given the sparse data. So it's something that's, you know, we would like to investigate a bit more, and it may just be that for that particular age group, there is maybe sort of like, you know, a different relationship, for instance, with the temperature. They're the young one. That kind of like may have quite different behavior from the others. So it may be that something, you know, needed to be changed in the model. And this is where maybe sort of like having, you know, a suite of models and then putting everything together in a sort of like model averaging way would be helpful. Yeah.
Alex, I think it's you.
Yeah. So the question that I had is really, so if you kind of take a big picture look at the sort of Bayesian workflow that you've presented, then the thing that I wanted to ask is methodologically, like, what are the bottlenecks? For example, like, and I don't know whether that's a bottleneck or not, but suppose you could run the Gaussian process model on like 100 times larger data. Would this help you? Or like what is, from the point of view of statistical theory and methods, what are the things you would like to be able to do, but you can't, either because the methods are not there or the computational techniques are not there, or because, like, you know, you try something and it just sort of doesn't work with current methodology? Like, what are the limits?
That's an interesting question, to which I only think I have a partial answer. I think one, certainly one limitation is, at least in this, you know, in the things I just sort of like presented, was the data availability. As I mentioned, we had issues with the data for Italy, for instance, and I think, you know, we would have quite a different picture if we had data rather than municipality at some sort of, you know, higher spatial resolution or sort of like grid or something, because, you know, some of the results, like the population density being negatively associated with excess mortality, was quite strange, honestly, you know, and not very believable. So definitely in some sense, data availability is a problem. Not necessarily in England. I think it's really, you know, it's really quite good, but as I said, that's not exactly the same everywhere. The other thing is obviously computation, because when you start looking at, several years, for instance, just putting all the countries together and running all the countries at the same time. For the first part of the talk I just gave, some of the countries, they were kind of like sharing boundaries, like Italy and Switzerland. But we couldn't, computationally, we were using INLA great, really fast, but still it was sort of like, running this was taking a very long time. And personally, I would have gone even to a higher spatial resolution and doing maybe, rather than provinces and rather than MSOA, sort of like doing something even smaller, because we all know, it's where the Bayesian approach makes, as Adam was actually saying, makes the more sense. You have sparse data, so you actually need some sort of modeling structure. But then it was kind of like, it was too much. Consider that we ran a similar model just for the first wave, just in Italy at the municipality level, and I'm talking 7,000 areas. And we had to sort of like split the country in different sort of like sub-region and run it separately and then putting everything together. So computationally, I think it's also a bit of a problem, which is also related to, it's kind of like the link between the two, which is getting even more problematic because, obviously, all the universities, they have like really high performance computing in place, which is great. Unfortunately, the health data, and particularly when you get to sort of like high spatial resolution, they need to stay within specific, behind specific sort of like firewall for security, information governance reasons. So you can't really merge the two. So you can't really use the highest performance computing with the highest spatial resolution of the data. And then, so basically, there's still work to be done there.
Mm-hmm. So with this said, I have some follow-up. But I also wanted to make the concluding announcement that we will now end the live stream. And I wanted to thank all of our listeners on YouTube for joining us today and remind that we have another seminar coming up next week. So check out our schedule on our website and please feel free to join us then. Thank you so much.